one of the things we're working on with this 3D biopsy program, and I want to ask you as a radiologist, you do biopsies. We have developed a needle that you can dial how big you want it. So you can go from 10 to 60. Mm-hmm. And right now what we have is 17. That's what most of the needles are. So we can vary if we see we want to get a good shot of the transition zone or what, we can dial it in. Do you see that as something that would be of interest to radiologists, not only in prostate, but other areas?
Oh yeah, definitely. If you can determine how large the area is that you're going to biopsy, that is crucial. The most problematic thing is the thing you see on the image and then to hit it with a needle. For example, I've been performing MR-guided lymph node biopsies deep in the pelvis, in the internal iliac region, in the obturator region, in the presacral region, and what you see there is that when you stick a needle up to the lymph node, it dances away in the fat. So if you then can, for example, increase the size of the needle and just shoot it with a big shot, you can perhaps get the entire small lymph node. So yes, that would be very much of interest. Coming back to the saturation biopsy.
I don't call it saturation. I call it mapping.
Sorry,
saturation
mapping.
is a term.
Well, you completely cover the entire prostate. We didn't do that with breast. With breast, the breast surgeon relied enough upon their fingers, what they felt, which is quite inaccurate, and they relied on imaging, ultrasound, mammography, MRI, and the question from me to you is, giving the morbidity and the expenses that is associated with 180 needles, do you think that is the right way to go for? Or when MR is perfect, you have a pretty picture by a good radiologist with a negative predictive value of 97%, do you really need then to get the extra 3% out of it, 180 needles?
Okay. So that was a good discussion. Well, the morbidity from transperineal biopsies,
Mm-hmm.
and 1,000 of them we've done, we've had one infection. So the infection is not it.
Okay.
You can have some transient erectile dysfunction,
Okay.
and so you have to be careful where you're putting the needles. You're putting a lot of needles in there. But we do this mainly in people that have had multiple negative biopsies. We have had people that have had negative MRIs, and we will do tests like Confirm MDX, which is another test, and that's positive, that helps us determine to re-biopsy the person.
Yep.
So it's not the person off the street. It's very selective.
No, it's a very selective patient.
And one of the things that we're trying to do is the needle will reduce the number of biopsies, because
Mm-hmm.
instead of having to do
Because
3,
yeah.
the pathology is turned into telepathology, where right now it's a lot of work for a pathologist to do 100 biopsies. In the past, they were happy because they got reimbursed per biopsy. Now Medicare and that lumps them together. So the future there, it's very select, but I think in some men it's helpful.